Steve, would you want to skip number 4 and combine 5 and 7 and just ask those questions?
Well, I wanted to ask in 4 whether anybody on the panel believes that it is important to have a specialization. And, personally, I don't, but okay.
Let me answer this. It's interesting. Should this be a specialty or should this be a primary care aspect? And what is this, a consultation or is this primary care? It could be either way. Again, my personal feeling is I don't think that certification guarantees you're going to see a good doc. Will there come a day when you see this fully accredited by every university? Yes. This will happen. So in time, I've seen this, I've gone through this every time. This will happen. You will see fully board certified from every university. We're in that interregnum period where what you're looking for is quality and you're looking for simpatico.
Good.
And enthusiasm.
Yeah, and passion. Does anyone want to address on the panel the issue of how to make referrals if you're an anti-aging doctor and somebody actually may need surgery?
The biggest issue is that I find in my practice that if there's a few doctors who I just don't, I mean, they're good, they're UCLA, they're deans and blah, 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 but credentials to me oftentimes don't mean anything because they're academicians. They're the director of blah, blah department, Cedars, they're UCLA head of pituitary, blah, blah, blah. Well, these folks are probably not the best doctors at all. I mean, even though they've written the book on the pituitary. So I go to the lower level people, send a few people over and see what the results are for my patients. So my patients are my guide as to who I put on what I call it my golden list of referrals. And after a while, you learn to know that. Since having a sports medicine background, I've become keenly interested in preventive cardiology. I find I probably do more cardiology because I do IMTs on every patient once a year to see if their IMT thickens or not based upon the program of vitamins or whatever you do in terms of lowering their lipids or fixed ratios or whatever, even low testosterone raises or stress increases your IMT levels. So IMT levels to me are a very good vascular measure of vascular aging. And it can be done simply in an office on a B mode. It's not a Doppler, it's just a B mode, simple. And ultrasound is totally underutilized in this country. IMT is interval medial thickness. In other words, if you look at someone's artery like carotid, it's the little layer of endothelial cells. If they get bumpy, lumpy, or whatever, and thick, and they're more than 1 millimeter, that's not so good. But if you put them on a nice program and all of a sudden it goes down to 0.7 millimeters, you're doing a good job. And I've had patients who I use you need surrogate endpoints. FDA uses these endpoints. And I think we need good endpoints to learn about outcome. Otherwise, we're kind of, how you feel is not necessarily your true biological outcome. So therefore, telomere length is another good outcome thing which is available now. But that's going to take, well, it's just like I do IMTs once a year. A telomere length should be done once a year as well.
Number 7 coming up is another way to discriminate good anti-aging medical practice, because usually that anti-aging doctor has a nutritionist or fitness specialist and nutritionist that can tell you about what kinds of supplements to take. How do the different panelists see these other aspects of their practice, and do they have on their staff the other people who cover them?
I'll tackle that one. I actually believe that if you offer it, you should do it yourself. Now, that doesn't necessarily mean that you have to do everything yourself, because these, for lack of a better term, I'm going to call them ancillary specialties, things like nutrition, exercise physiologists, exercise counselors. They may know a lot more than you do as a physician about it. As a matter of fact, one of the things I think you and I both agree on is there's a real disconnect between what the public wants and what they get from physicians, which is one of the things that's gotten us into this mess that we have now to begin with. If we were offering people what they really wanted, they wouldn't, the growth of alternative medicine, which is good for us, wouldn't be where it's at. So it's a good thing, but I try to do everything that I offer to my patients, I either get the counseling from the people that I would offer, or I actually do the programs myself, and it changes. Again, Joe and I were talking earlier, we don't work out the same way we used to. We don't eat the same way we used to. And this is an evolving thing. So you have to be on top of it, just like you have to be on top of all the other things that are happening that Carlos mentioned. From the primary intervention standpoint of anti-aging, diet, exercise, supplementation, lifestyle modifications, as hard as they may be, these are the things that patients want. And if they walk into your office and they see you as a living embodiment of what you preach, they're a lot more likely to take the inspiration from it.
I thoroughly agree with that. And I agree also with the adjuncts that are on the listed on number 7. It's hard for me to understand how you could possibly be an anti-aging physician without those resources. But I'd like to add 2, and one of them I referred to earlier, which was the emotional component. I mean, you just cannot be optimally healthy without having that issue addressed in some way, shape, and form. Typically, it's going to be difficult to do internally, so you would want to hire a consultant to do that. There's a number of good energy psychologists out there. It's profoundly effective. And another one is really 21st century medicine, which is energetic medicine, where you use some type of tool, either a human clinical tool like applied kinesiology and different variants, such as Dietrich Klinghardt, one of my mentors, developed autonomic response testing, which is a more sophisticated way of muscle testing. But it can tell you if these supplements, that we're identifying and perceiving there's some benefit, but it may not be beneficial for everyone. And ultimately, it comes down to your unique biochemistry and genetics, and you want to test that specific supplement for that person. So we always, in our practice, we have a number of these energetic therapists, and if that's uncomfortable, there are certainly tools. They typically cost about $10,000, like EAV, electroacupuncture machines that are very sophisticated and can make these types of assessments too, and help really identify the blocks, the hidden barriers that are helping a person to go from a base level to a much higher level of health and wellness.
One quick thing, Phil mentioned simpatico, absolutely critical.
Part of the answer to this question really depends on the astuteness of the physician and what his business model is. So you can have a business model like mine, which is really small. I have 2 support staff. One's my daughter. And I've come from a background where really, throughout emergency medicine, urgent care, I've become self-sufficient so that I can take care of virtually any cardiac problem possible. So my model is I do it all. The other model could be you go to a large center like one in New York City where you're seen by a PA, you're seen by a nutritionist, then you're seen by an exercise physiologist, and you're seen by all these people, and then you spend 15 minutes with the physician. I don't think that works very well. What I found out is nobody's doing physical exams anymore. It's become passé. When I do my physical exam, I know what's going on. I don't have to order quite as many tests because I do it by old-fashioned physical exam. So this is kind of the model. There's no one way that's the right way or the wrong way. It's you can do all of that. You do have to be good at all of these. You have to be a good nutritionist. A background in biochemistry helps. You have to be really good in fitness. But you can either segment it out because that's the business model, or you can do it all. And that's kind of dependent on what you feel comfortable with.
I think that issue is really good about the physical exam, because I think even though they give you a history, when you look at somebody's hair and a woman, it's thinning out, and then you go, oh, maybe there's excess androgen syndrome in a female, which can be not necessarily just polycystic ovarian syndrome, which is really a metabolic syndrome, but it can be a lot of other things. Or all of a sudden, a male's got a little gynecomastia. Well, that's a whole big trigger. Then there's people with erectile dysfunction. That's another trigger to lead you into an investigation. And then you feel somebody's prostate. Well, it's really interesting. The more prostates I feel, the more I can predict their PSA levels. A small prostate, this person's got low testosterone, and their PSA will be small. And, it's kind of like the guys who've been hypogonadal for a while just don't get big prostates. Anyway, there's a whole new thing that I'm working on with the Urological Journal Club next week with Milken Foundation, where they found that recently, which is kind of interesting, when you do a radical prostatectomy on a patient, they take eugonadal, hypogonadal men and do a prostatectomy on a hypogonadal man. When you take out his prostate, is testosterone goes up. So there's a whole new area of endocrinology where prostate has a role in LH, or the whole pituitary hypogonadal axis. So prostate, and there's Abe Morgenthaler and a bunch of other people who've got these new theories of saturation models and blah, 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 and that, testosterone cancer connection doesn't exist anymore. But so there's some really interesting things that just by feeling that prostate, and I can also predict by looking at a biochemical panel like a creatinine. When I see a patient who's got a low creatinine, that tells me they've got low intake of protein, they're muscle wasting, or if they've got a very high creatinine, they're usually the opposite. It might be a bodybuilder. So, or they're maybe a little bit dehydrated. But I can tell from these numbers, eating triglycerides. To me, triglycerides tells me what their diet is. I can tell people, hey, your triglyceride was 65, 70, now it's 175. What have you been eating? I mean, it's like, to me, in that chemical panel, I can predict, or more or less guess, to some degree of 80% certainty maybe, that what their diet and lifestyle is like.
I have 2 words for the audience: fish oil.